Hello, we'll be starting the webinar in 1 minute.
Good afternoon, and thank you for joining Clear Health Quality Institute's final installment of our Fall 2017 educational series, entitled CHQI Overview, Quality and Accountability in Healthcare Accreditation. Conversation will be moderated by Gary Carneal, CHQI's founder, and will include speakers Michael Reisman, CHQI President, and Doug Clark, CHQI Executive Director of Accreditation Programs. Before we begin, just a few housekeeping rules. Today's conversation will be recorded for those who were unable to attend. This will be available on our website at www.chqi.com. Once the webinar begins, attendees' phones will be muted, but feel free to submit your comments and questions via the chat box. I'll now hand this over to Gary Carneal.
Good morning or good afternoon, depending where you are in the country today. I'm thrilled to be able to moderate today's session. I've had my background is I've helped run a number of different accreditation organizations over the years and have worked for a number of different trade associations, including the National Association of Insurance Commissioners, a group now called the American Health Insurance Plans. I've been running a consulting firm the last 10 years called Schooner Strategies. So I'm pleased to be here and to help moderate today's session. Just a little bit more detail about our speakers. Michael Reisman joined Clear Health Quality Institute in June. He currently serves as CHQI President. Michael brings over 12 years of legal experience to the organization, and most recently he served in the New York Attorney General Healthcare Bureau, which protects the rights of consumers in the healthcare system. And during his 5-year tenure as Assistant Attorney General, he was instrumental in enforcing the federal and New York mental health parity laws, which resulted in 8 settlements with health insurance companies that greatly improved their mental health and addiction benefits and returned more than $2 million to consumers. Michael also played an instrumental role in investigating and settlements regarding mobile health applications and pharmaceutical marketing. He also has worked in a private law firm for many years, and then he also, before receiving his law degree, was a mental health counselor and worked in both inpatient and outpatient facilities. So we're thrilled also that Michael has joined the Clear Health Quality Institute team and has helped heading up the organization. In addition, it's my pleasure to tell you a little bit more about Doug Clark, who serves as the Executive Director of Accreditation Programs. He joined us also in June, and he oversees all the emerging accreditation programs which you're about to hear about within the organization. And actually, Doug and I met when he was working for the American Telemedicine Association, overseeing their accreditation program, which he'll speak to. And we worked together 6 or 9 months as I was assisting the American Telemedicine Association in its accreditation program. And as you'll hear in a moment, the ATA has formed a strategic alliance with the Clear Health Quality Institute to launch the next version. His previous roles include experience as Associate Director and Lead Accreditation Specialist for the Commission on Accreditation, Physical Therapy, and Education, and Chief Academic Officer in higher educational settings and as faculty member at a post-secondary level. So he really brings a lot of expertise to the table. And he also has been the point person on the telemedicine standards development, as Michael has been the point person on the parity standards development. So today, the webinar will be in 3 parts. First, we'll give you a little bit of an overview of this brand new and exciting organization. We'll drill down and talk a little bit about the 3 accreditation programs that are being developed now. And we'll talk a little bit about the future of quality benchmarking. So, you know, I seem to keep on coming back to accreditation in my career. I think Clear Health Quality Institute represents the 5th accreditation organization that I work with, and I think I'm on the 23rd and 24th accreditation program that I've helped bring to market in healthcare. So obviously I'm very passionate about you know, accreditation and how it can promote quality, improve performance, etc. In today's webinar, we're really going to focus a little bit on, in terms of the CHQI overview, a little bit of the background, the accreditation overview, how is CHQI different, give you a little bit of a perspective on our standards development process and accreditation review process. You know, it's interesting. Starting probably in 2015, I began to have a number of meetings with, I got involved with the mental health parity public policy arena for a couple engagements, and I started meeting with federal regulators and just kind of did a little bit of a survey of the landscape. And I realized with all the activity on parity enforcement that there was really an opportunity to work with the industry and the other stakeholders to develop an accreditation program in the traditional sense that helps provide some fidelity and detail to potentially how you implement the parity law. And after a couple of meetings with the federal government, and I was convinced that would be a good thing to do, and there was really no existing parity accreditation program. So Michael, again, will tell you a little bit more about that, but that was probably one of the 2 major reasons why CHQI was found this past spring. The other was through the strategic alliance with the American Telemedicine Association. It became apparent that although the ATA was a subject matter expert, obviously in the telemedicine, telehealth fields, they would benefit by having a third-party independent organization work with them on accreditation. So I think those 2 factors really led to the formation of CHQI. The other thing, too, is that throughout my tenure in terms of developing medical management accreditation programs, PPO, just the full spectrum, you know, accreditation, when done right, really can effectively fill in regulatory gaps and kind of help promote, I think, you know, best practices going forward. So you'll hear a little bit more about that today. So, you know, again, the 3 accreditation programs that we're working on right now is the telemedicine accreditation program. We're hoping that that will launch in January after working on that for a good part of the year. And then the mental health parity accreditation program will follow soon thereafter. And then you'll hear a little bit more about a new effort called the Insurance Appeals Accreditation Program. We'll talk a little bit about that. And again, this comes back to some of my earlier work. In the early 1990s, I was legislative counsel to the NAIC, National Association of Insurance Commissioners, where we really developed the laws and regulations and appeals process. And some of that has been captured in some other accreditation programs, but I have not really seen a whole lot of updating in terms of the health insurance appeals process in 25 years. And so that's just one of many reasons why we've also decided to move forward on the insurance appeals. So with that, I'll turn it over to Michael to talk a little bit about how CHQI is different. Michael.
Thank you so much, Gary, and it's great to be on this webinar today with everyone. Thank you so much for joining us. Well, I'm really excited to talk about how is CHQI different because, as Gary mentioned, I bring to CHQI years of experience as a lawyer, including as a state enforcer. I also bring my clinical experience, and so what we're really focused on right now, we're a small company, we're a startup, but we are focused on things that are emerging, things that may and have been described as revolutionizing healthcare. Telemedicine, certainly. We believe firmly that mental health parity is something that is and will continue to revolutionize healthcare because we'll get into the details of parity in a few minutes, but I think it's fair to say that providing better access to evidence-based mental health and addiction treatment is essential to addressing many social problems that we face in our country right now, and also in reforming the healthcare system and in lowering costs. So we're focused on these new emerging treatments and areas of healthcare. We're also focused on creating new national standards where none have existed before. In the telemedicine space, as Gary mentioned, obviously ATA is a leader in the industry, but we all understand that there are still lots of differences in how the states approach telemedicine and regulate it. And in the parity area, as we'll get into in a few minutes, there are a number of different approaches to parity, and I think it's also fair to say there's a lack of firm understanding of how to show compliance. So those are just some of the regulatory and operational gaps that we're trying to fill in. And we're also trying to ensure that our accreditation requirements are leading edge. We'll get into the process of how we're doing that in a few minutes, but maybe if we move on to the next slide, I think this really illustrates our process that in creating these new standards, cutting-edge standards as we think of them for emerging practices, we are bringing together industry and consumer representatives to identify best practices. Now, we, of course, are looking at the landscape of legal and regulatory requirements, but we're trying to be very forward-thinking. We're trying to focus on, what is it that telemedicine, what is it that parity ultimately is trying to achieve? Because we have industry as well as advocates represented on our committees, we understand that, healthcare, among many other things, is a business, and there have to be ways that accreditation can promote efficiencies in terms of ensuring compliance. And then finally, because we are so focused on, as an organization, on consumer protection, consumer rights, my personal background is very focused on that. We have that perspective in developing our programs and our standards to promote transparency and fairness, because we think that that is going to be the way to develop a better healthcare system.
So Doug, why don't you share with us a little bit about the CHQI standards development process and accreditation process.
Well, thank you, Gary and Michael. It's a pleasure to join both of you today and our audience as well, and to share a little more as part of our efforts to be transparent and very open about the work that we do here at CHQI. Really the most fundamental and core function of what we do is the development of standards that basically provide the foundation for our evaluation frameworks, and certainly provide guidance for applicants to be able to document compliance with these standards. So I did want to talk very kind of provide an overview of standards development process. And we do run these processes parallel for our program. We follow the same basic process for each. We have different stakeholders around the table. Ultimately, and again, they represent a diverse geographically and otherwise as far as the types of stakeholders or individuals that might have an interest in a particular program that we're developing at the time. So again, we want to make sure that consumer advocates, industry, clinicians, payers, I mean, whatever their role is within that particular program area, that indeed that perspective is represented, that their voice is being heard at the table as we try to come up with the best possible standards to evaluate a broad and diverse range of applicants and organizations over time. So again, we are committed to developing really a very transparent and helpful process in the sense that we are developing interpretive guides for each program, which includes not just standards, narrative, or things that have to be further explained in the process, required documentation, and also there will be information about the survey process, which we'll talk about a little later more in detail. So again, we also, as part of our standards process, both parity and telemedicine right now are kind of in final stages, moving towards public comment periods with some final work and editing, and ultimately to beta testing with initial applicant organizations. And so those become 2 data points for our programs to be able to further assess the quality of the standards that we're developing, the integrity of those standards as it relates to the outcomes we've identified for these programs in the process at the end of the day. So once we get that data back and our standards committees make any final tweaks or revisions to the standards, ultimately they will vote on the standards as a committee, recommend that they go to the CHQI Board of Directors for final approval. And once those standards are approved by the CHQI Board, then we'll be able to release those for the first wave of applications. And so again, that's pretty much our standard process. We are committed to a regular revision cycle, and we will be looking at different metrics. We may be looking at frequency of citations. We may be looking at committee decisions as far as number of papers versus positive decisions at the end of the day as possible indicators of why we would need to trigger a review of the standards, independent of having a regular review cycle established to make sure that they're always reflecting current practices within the various industries. And then finally, we certainly are working very hard in concert with our standards committee members and ultimately down the road with our accreditation committee members. We'll be working with them to identify specific outcomes measures for each program. And as everyone knows, the trick for us is balancing between being overly prescriptive and not diluting it to a point that the standards actually are not measuring what at the end of the day. So
I was wrong there. 20. But if they do MRI only, they only have to do 18.
So that basically is our process in a nutshell. And again, that's been consistent with the process Michael's been following as he's been kind of shepherding the parity committee, and certainly as I've been dealing with the telemedicine accreditation committee. So again, that's basically the process, and it certainly supports the accreditation review process that we've established for all of those programs down the road as well. So, and I will touch briefly on the accreditation review process now. And again, it's not, there are some different elements than you might have experienced maybe with other accreditation experiences previously, and we're working to try to innovate that process as much as possible. But again, each one of our programs will have an online application process. We'll have a secure, customized submission portal with the goal of trying to streamline that submission process to make sure that documents can be submitted as well as reviewed by surveyors and accreditation committee members in a very efficient manner and to ensure that no information is missed. We are currently continuing our discussions about composition of our review teams for our desktop reviews and survey visits. I can tell you that we are committed to making sure we have the best possible folks out in the field with the appropriate expertise to evaluate the various aspects of our program. There's either going to be a tabletop on-site review component for our programs. In some cases with telemedicine, there may be certain business models that may allow for an entirely virtual demonstration for some of the direct-to-consumer services out there, but we fully anticipate there may be a clinical focus visit involved for some telemedicine services as well. We are committed to a collaborative and educational process as staff, our program managers, right now Michael and I certainly, as we get calls from interested organizations, are happy to provide clarification and guidance about the standards based on their current state of development, really where we're looking at as far as survey process requirements, beta testing, et cetera. But again, we as staff are here to support our applicants through the process. We're there to answer questions, to coach, to help provide guidance as far as what's too much, what's too little. Certainly, as that becomes more evident to us as the committee continues, as well as the surveys, to apply the standards. Our applications are all blinded to ensure objectivity during the review process. So accreditation committee, once they review that, have no idea who the organizational applicant is. But they will see information related to that application, final recommendations from survey teams before they make a final decision. And then we also will afford any organization that receives an adverse decision in the accreditation review process an opportunity to appeal that decision to an independent body beyond the accreditation committee for resolution and final disposition. So again, a pretty standard process, but again, we're looking for ways to innovate as we can.
Thank you, Doug. Just before we transition to the telemedicine kind of detailed overview, one of my favorite aspects of accreditation is really kind of the formation of these broad array of volunteer stakeholder groups, both as expressed in the Standards Committee and as expressed in the Accreditation Committee. It's actually kind of humbling in terms of the investment that our colleagues, including many of you on the phone, will make in terms of actually developing the standards, running the Accreditation Committee, and serving on the board. So that's one of my favorite parts, is where you really have, in this very kind of partisan world we live in, that you really have people kind of doing the right thing and having earnest and open discussions. And that is one of my favorite parts. And, sometimes, like as expressed, as you'll hear in a minute, in the telemedicine standards, it's really about getting the right configuration based on our emerging technology. And then with parity, it's really about bringing a consensus together. That really hasn't happened by all the stakeholders up until now. So, Doug, why don't you go ahead and go into a little bit more detail on the telemedicine accreditation program, since that's going to be the first one out of the gate in January.
I appreciate that, Gary. I don't think anybody on the phone is probably questioning the role of telemedicine in healthcare these days. It's almost becoming synonymous with healthcare as far as certain types of clinical services. And organizations are certainly leveraging technology in any way they can, purposefully and intentionally, to increase access, ultimately decrease cost, and to achieve the same, if not better, patient outcomes than maybe we're seeing in traditional brick and mortars or residential settings. So again, we know that this is a growing industry. It is a largely unregulated industry at the end of the day. And so again, I think payers, regulators are still working, and I think the work that we're doing can help advance their understanding and help their policy and decision making at the end of the day about how to best regulate this industry. They may find that it will be through accreditation at the end of the day, or some other regulation. But again, it is certainly is a growing industry, and there are certainly serious consumer protection issues that arise in the telemedicine sector, and I believe that we're working to address those within the telemedicine accreditation program standards here at CHQI. So as far as the need, again, I think I've touched on this a little bit in kind of my overview, but we are looking at increased access, extending the reach of healthcare services, particularly to critical, underserved, rural access areas. Where we're seeing rural critical access hospitals shut down almost weekly these days. So we're seeing fewer and fewer services being extended out to probably some of the most some populations that are probably in the most critical need. And so telemedicine really does afford health institutions and organizations and providers an opportunity to really extend that reach. Also, in addition, it allows us to provide 24/7 coverage in areas where it may not have been available ever at all. And so what we're also seeing in a lot of the initial data coming out of direct-to-consumer as well as patient satisfaction surveys, certainly from the organizations we accredited at ATA when I was running the program there for them, we're seeing a much higher level of customer and patient satisfaction at the end of the day. Telemedicine allows us to take a lot of those extra stressors, if you will, of traveling to a site in order to see a doctor, having to work around really tight schedules as far as appointments. So there are things that have freed consumers and patients up in a way to allow them to really access and embrace their healthcare options even more than maybe they had previously. And ultimately, at the end of the day, telemedicine becomes not a panacea, but it becomes a very important policy opportunity at all levels to ultimately help us contain cost of healthcare over time, because there are greater efficiencies, certainly in using technology to reach larger patient populations and ultimately bring in providers that we'd have to do at a higher cost in other circumstances, that I can now use telemedicine, a video consult, to actually access that expertise and to benefit my patient that I may have under my care. So the great thing about the telemedicine accreditation program at CHQI is that we really were, I think we've benefited from a very strong foundational program that we had partnered with ATA earlier this year to basically manage. As Gary mentioned in some of his opening comments, we wanted to make sure, and I think ATA wanted to make sure, that the perceptions about the program existing within a member association, members approving members, they just felt that there was, certainly was a perceived conflict out there about how objective that could be. So the opportunity to come to CHQI and create this new independent review organization, specifically that will be focused on ATA's accreditation program as far as total program management. And again, that's something I want to stress, is this program has been removed from ATA's control other than the relationship, and ultimately they have afforded us the opportunity to provide those management and support. And again, we brought the core set of standards over from ATA, and we've now expanded the scope of that original program as well as the standard set to be inclusive of all forms of telemedicine and business models, including direct-to-consumer or consumer-to-provider, provider-to-consumer, and provider-to-provider models. So again, yep. Finally, the one thing I will mention here is we do have a pretty tight timeline. The Standards Committee's been meeting for the last 10 weeks. They started meeting back in August. We've been having weekly calls, sometimes twice a week. But again, they've been working to expand these particular standards, building on the ATA Foundation. We have a public comment and beta testing period starting later this month. We're working on that now, and the Standards Committee has a face-to-face meeting tomorrow. So again, we are working to finalize that first set of standards to go out for public comment and beta testing. In January 2018, we expect, following the conclusion of the beta test around middle of the month, that we will be reviewing that data, making any changes through the Standards Committee, as will, I'm sure, Parallel will be following a similar process. And ultimately, once approved, the Standards Committee will send those to the to the CHQI Board of Directors for approval of those standards, and we anticipate first wave of applications in late January, early February of next year. The final thing I will mention is the Standards Committee and CHQI are committed to version 2.0. Actually, that we're currently working on, but I think the next manifestation of this, we're going to be looking at specific use case standards for all the various clinical service lines, and that will help us as far as being able to drill down into quality metrics and outcomes for each type of telemedicine that's being practiced currently. Final thing I want to mention very quickly is the CHQI Telemedicine Accreditation Portal, and it's not to promote telemedicine per se on this call or this webinar today, but it is to give you an idea of how we're designing each one of our customized submission portals. So there'll be one like this for our parity program, for the insurance appeals program. We'll each have these types of things that will be focused on your particular organization, your particular accreditation needs, and your application documentation. So again, it is a very user-friendly system. You can see you can access various parts of the application, looking at the tabs there on the diagram. And again, we are here to troubleshoot and work with you through the process as issues arrive, but we're doing a lot of testing on this end to make sure that we're decreasing that headache for you on the other. All right?
So, Doug, let me just, before we just switch over to Michael on parity, let me just ask you one quick question. So what is it about the standards that we're developing now that really makes it unique as related to telemedicine? So, one of the issues I think a lot of people have is, oh, here's another round of, core process and structure measures. What is it about the telemedicine transaction that we're capturing, or what's an example or two that really will add some fidelity that will not only potentially fill regulatory gaps and become part of national RP requirements, but really move the industry forward? Because of course one of the concerns is that telemedicine represents such a broad array of services. So just give one or two examples of really kind of what is the meat on the bones, if you will.
Yeah, so I appreciate that question, Gary, because I think that is something that everybody struggles with when you look at these types of national standards and frameworks. And so I think part of our model with the modules focused on each one of the different types of delivery models I'll take provider to consumer services, for instance. One of the things we're really focused on there, because this is an area that deals with use cases like remote patient monitoring, tele-rehab. I may be using exercise equipment. The question is, have I been trained by a physical therapist before at home? They're monitoring me in that home setting using a video. Have they showed me how to properly use the equipment and to regulate the exercise that I'm doing? So again, there's the end user proficiency, and along those lines, I mean, those are specific standards that we don't necessarily see right now, even in the previous ATA standards. So we've built upon those to make sure that we're very keenly focused, or acutely focused, if you will, on patient safety and ultimately the outcomes of not just process measures, but also outcomes as it relates to patient improvement and health. And so I think that's a good example of the end user proficiency. It's not a matter of just saying that people possess the knowledge, or it's not enough to say we train people about how to use equipment. There are different considerations about the types of equipment they're being asked to use. There's a diverse array, and I know Michael working in this space as well and dealing with some telemedicine at the AG's office. There's just a diverse array of technological applications and innovations out there. While our standards don't address every brand name, every type of platform, again, the standards are addressing really the functionality and how to best utilize that in a safe, competent, and effective way for the patients who are the end users. So the other thing I will mention is we are really drilling down in this process to build upon, I think, really a lot of the recent recommendations that came out for the National Telehealth Outcomes from the National Quality Forum. And we are now starting to drill down to create those specific outcomes measures and quality metrics for these different types of telemedicine practices that we just haven't seen in previous national standards dealing with this. So we want to continue to build on that national conversation. I think that's an opportunity here for us at CHQI that all of us are very excited about, knowing that we can use these standards to really move this process and this discussion forward nationally. So you'll see that with the standards, and you'll see, and I'll just kind of sum it up, one of the standards committee members, who's a CMO with a very large provider-to-provider group in Virginia, his first comment when he sat down 10 weeks ago at the table was, I've never seen a set of standards, even as we're starting our work, that come so close to describing what telemedicine is and what telemedicine providers actually do. And this is somebody that has been through many different types of accreditation through the years, but I think that really gets at the heart of how we're going to differentiate ourselves in the marketplace.
Great. All right, thank you, Doug. That's very exciting. So, Michael, why don't you kind of give us a little bit of view of the Mental Health Parity Accreditation Program?
Well, great. Thanks so much, Gary. I wanted to start off talking about parity by talking about how unique it is to have mental health parity laws in the first instance, leaving accreditation aside for the moment. The Mental Health Parity and Addiction Equity Act, which was enacted in 2008, and all of the various state parity laws are, in essence, civil rights laws. They were enacted to remedy the historic discrimination against folks with mental health and addiction disorders. What makes them, of course, challenging is that they are codified in insurance laws, which are, needless to say, very dry. They focus often on very sort of mundane procedural matters. So here we have a set of laws, and we're talking about the federal law as well as state laws, which are very similar in many ways, which are designed to promote a public policy goal. But we're trying to enforce them within the construct of insurance laws, which, as Gary mentioned earlier, in certain ways, the utilization management system overall has not really changed very much over the last couple of decades. So we're trying to promote this goal within a system that is flawed in many ways. And I think that has resulted in some of the challenges that we're seeing with respect to parity enforcement. So to bring things to the present day, one of the main reasons why I personally became involved in parity enforcement and my former position at the New York Attorney General's office is because that office, my former boss, Eric Schneiderman, and all of my former colleagues were very much focused in 2012 on parity as a way to address the opioid epidemic. And as we all know, tragically, things have continued to get worse, and perhaps they will get worse with opioid overdoses for the near future. But Enforcing parity laws is one way of dealing with this epidemic, of ensuring that folks have access to treatment. We also have a national suicide epidemic in this country that doesn't get talked about as much as the opioid epidemic. So we need more and better treatment. Now, going back to my experience working as a mental health counselor for 10 years in California, New York City, at Bellevue Hospital, and in the Czech Republic, I did see that there were forms of mental health and addiction treatment that, in my personal judgment at the time, were not effective. So, there's a balance here between promoting access and ensuring quality, and I think that the conversation in parity right now is about the nitty-gritty of compliance, but I think what we'd like to see here at Clear Health Quality Institute is a transition, or at least a merging of the focus on parity with a focus on better treatment, better outcomes. Now, these parity laws are actually very complex because insurance is complex. That makes compliance difficult. It's even more difficult because there's an overlapping jurisdiction between federal and state regulators. I'll just say in one of the early versions of this slide, and we've spared you all on the phone from this, but there was a map of all or a pie chart, I should say, of all the different types of health insurance and who regulates them in terms of parity and otherwise. And all of that really is to say that because you have state regulators, you have federal agencies, multiple federal agencies involved in parity enforcement, there are inconsistent approaches, which frustrates the industry because they don't know which standard that they're going to be charged with. And it's also frustrating for advocates and consumers because, at the end of the day, surveys have shown that consumers, number one, lack basic knowledge about health insurance, and that's really kind of something that as a society we need to fix. But in particular, most consumers have not heard of mental health parity laws. I think the latest survey from the American Psychological Association showed that less than 5% of Americans know about the parity laws. So, one of the purposes or goals of accreditation is to bring this to the fore, to say, okay, it's not just something that parity compliance is not just something that's going to be the focus or discussion among regulators, but it's going to be something that we're going to have a national conversation about. So in terms of this process, actually before I joined CHQI, a standards committee was formed that includes more than 20 brilliant people, very passionate people from health insurance companies, providers, from provider organizations, both APAs, as well as consumer representatives. And I will say I thought when I joined Clear Health in June 2017, I thought I knew a lot about parity, having conducted 8 investigations, each of which resulted in settlements and lots of restitution to consumers, lots of reforms. But I have learned much more in the last few months about parity, the challenges, what it should be from the Standards Committee. So what we're trying to do is to fill in gaps in the regulations and guidance because the federal agencies have done a great job of, over the years, providing increasingly granular guidance, but we still see that there are some pretty big gaps in what parity means, in particular in the thorny area of non-quantitative trim limitations or NQTLs. So we're trying to work towards consensus on at least what constitutes an approach to these issues. Now, I think it's important to say, and I say this in every conversation about parity accreditation, accreditation in this context is not an assessment by our organization as to whether an entity, a health plan, a benefits administrator, whether they comply with the parity laws. We're just looking to see that they have a framework, that they have done the homework, that they have done the testing to promote compliance. We are, as Doug mentioned, I don't know if I'd quite say we're in the final stages. I'm cautiously optimistic that we're moving towards consensus and that in the first quarter of 2018, we're going to go into a public comment phase with beta testing, and we'll be in a position to launch the program. in terms of goals, I'm a very problem/solution-oriented person. So I mentioned earlier that the problem in this area is, a wide range of approaches to compliance. So what we're trying to do to solve that problem is to create a uniform set of national standards for assessing compliance. So, we're trying to drill down on the tests, and even in the area of quantitative trim limitations, which focus on things like co-payments, and numbers are more precise than concepts like prior authorization. But still, even in the QTL area, we need to have a more uniform approach so that everyone understands what they're expected to do. We're trying to develop this program so that plans can prepare for regulatory audits and market conduct examinations. And we also hope that regulators at the federal and state level will look to our standards for assistance in their work, that we will raise the bar for the industry and will educate them as well as state and federal regulators. And ultimately, it's all about, from my perspective and from our organization's perspective, and really from the perspective of everybody on the Standards Committee, that we're trying to help consumers by promoting better access to treatment and effective treatment.
So, Michael, I have a question for you. With the emphasis on creating a true national standard, or one that's, kind of a core set of principles that can be customized, with all the additional emphasis on regulatory enforcement as expressed through, state regulator, federal regulator, litigation, AG's office. What else is Parity Accreditation going to do in terms of, moving the ball forward?
Well, that's a great question. I think one of the areas in which we're really doing some great work, and we're not there yet, but we're in a very good process with our Standards Committee, is focusing on really cutting-edge issues like network adequacy and provider reimbursement. I call that Parity 3.0, and I think in the interest of time, I won't go through Parity 1.0 and 2.0, but I think where the rubber hits the road with Parity right now, where the biggest sort of debates are with respect to network adequacy and provider reimbursement. There was some research published recently on these issues, and what we're trying to do is really break those issues down into metrics and concepts that the plans can look at. Now, we might not say, okay, there's a particular number of what constitutes network adequacy, but at least we want to make sure that plans have a process in place to assess whether they have an adequate network of mental health and addiction providers, and to perhaps remedy any deficiencies. So I think it's really focusing on these really challenging issues that really have not been addressed so much in the guidance.
So is it fair to say that the end product, that being the accreditation program, including the standards and interpretive guide, will help the industry with creating a roadmap of really kind of?
Yeah, that's exactly right. I mean, I think that metaphor is particularly suited to this discussion, because what we're trying to do is give them the ingredients and a recipe for complying. Now, again, we're not going to make the assessment as to whether they do comply, but it stands to reason that any entity that gets accredited by us, showing that they meet these very robust standards that have been vetted by this expert committee, they're in pretty good stead. I mean, that's not to say that there might not be issues down the road, and state regulators, federal regulators may reach different conclusions about, or may reach their own, they will reach their own conclusion about compliance, or there may be, there is litigation in the parity realm. I'm sure there will continue to be litigation, but we believe that the entities that get accredited will be better equipped to deal with these sorts of challenges.
Great. All right, well, let's move on. We've got just over 15 minutes left. I want to make sure we get in the final two parts. So, Mike, why don't you tell us a little bit about the Health Insurance Appeals Accreditation Program? This has just started. It's getting underway. Just tell us what we're up to here.
Sure. Yeah. I mean, this in a way is kind of a parallel program to Parity. We're focused on really building this from the ground up. I think there's a lot of frustration that consumers have today with the health insurance appeals system. We had some reforms in the appeals system that were embedded in the Affordable Care Act, yet still we see, and maybe it's because of the rising cost of healthcare, the rising cost of prescription drugs, there are lots of advocacy organizations that are calling for change in the system. There's an increased focus, of course, on what some view as wasteful or unnecessary healthcare expenditure. So, ultimately, this is about balancing the goals of, I think we all share, of having a better, more efficient healthcare system with providing individuals due process rights, because a lot of the measures of healthcare efficiency, and when we talk about value-based purchasing, which we'll do in a few minutes, those are aggregate measures. We're looking at large segments of the population and saying, okay, are people going to get better, and is the treatment efficient? But we still need a system in place that gives individual human beings the right to challenge adverse determinations or denials and educates them. And also, I think from the health plan side, we see that there is, health plans are spending lots and lots of resources and human resources, financial resources on an appeals system that may not be very effective. And, that is maybe contributing to this dissatisfaction that folks have. So, in a way, we have a very ambitious goal of reforming the healthcare system, in part by reforming this appeals system to make it easier for consumers and their representatives, which are often their providers, to file appeals, because that's going to promote due process and transparency, but it's also going to promote ultimately better decision making on the part of the health plans. So in terms of our process, I mean, this, as we've mentioned, is just in the formative stages. We have an outstanding group of folks on our standards committee. Again, a wide range of perspectives: health insurers, independent review organizations, providers, consumer reps. We're starting from scratch. We have the background of the recent sort of last 20, 25 years of rules and regulations in the appeals area. We have the recent ACA-related reforms, but we understand that all of this together is still not sufficient. We're targeting our beta testing, public comment, and launch for the second quarter of next year. And our goals, again, are to promote a more rational process for ensuring quality, evidence-based treatment. And we have the somewhat ambitious goal of reinventing the utilization management system, and which ultimately, I think, relates to the reforming the healthcare system by fixing the appeals system.
So, Mike, let me ask you kind of to just clarify. So there's lots, thousands of laws, individual statutory regulations impacting when a health plan makes an adverse benefit determination, whether it's based on medical necessity or administrative denial. There's kind of a robust complaint process. So there's a lot of stuff out there. So why are we doing this?
Well, what we're trying to do is integrate these various concepts, because unfortunately consumers don't understand the difference between a medical necessity denial and a so-called administrative denial. And very often, because of the patchwork of state and federal laws and regulations, I mean, the laws themselves are confused and confusing. And that creates confusion on the part of the health plans, because they're trying to comply with, if it's a national organization, they're trying to comply basically with 51 different systems. I mean, that's just, unmanageable.
You skipped the U.S. territories, too.
Okay, so yeah, it could be 55. So I think, again, this gets to the point of, this system was developed, the internal appeals system, or the sort of core of the rules were developed 25 years ago. We've had external appeal now for 15 to or so years. We have this, sort of, more robust set of rules that govern certain types of the Affordable Care Act exchange plans, and there are some rules that apply only to self-insured plans. And really, I think what we're trying to do with our program is establish a baseline of that's consistent.
Great. Thank you. Well, that's, quite an undertaking, and obviously I'm a little biased, but I think it's something that, having been involved 25 years ago in the formation of the initial appeals process, I'm looking forward to seeing what we can do, again, working with this expanded community going forward in terms of creating a national set of standards that would activate providers, consumers to file complaints, but also, maybe shore up how health plans are processing complaints so they can, deal with it with a risk management perspective and perhaps use advanced medical management systems going forward. So part 3, as we wrap up, is really talking about the future quality benchmark. So, of course, the pressure point we deal with is we just don't want to be another accreditation organization. We really want to make sure we're adding value. And so I think it would be good, maybe to start, Doug, with you in terms of, what is kind of the status quo, what are some of the current quality creation themes that make up today's, culture in terms of accreditation, and then we'll turn to Michael to provide a little, some observations in terms of where we're heading.
I appreciate that, Gary. I mean, certainly as you sit back and as a startup and a new accrediting organization, we've had a chance to really sit back and kind of survey the landscape and the model of accreditation that's out there. And you certainly have great experience, I think, with the models that are out there and helping to really shape and create a lot of what we know as healthcare accreditation today in your previous role and contribution. So, there's nothing to say that the current system doesn't work. The current system does meet organizational as well as stakeholder needs. But again, I think it's the focus of the current model that really we feel as healthcare is continuing to transform in many different ways, that we've started to think that it's time now to start rethinking the healthcare accreditation model as well. And so again, for many years and from its inception, we've been focused on process and structure measures, what I like to call, when I'm talking to applicants, housekeeping. I mean, so much of it is about how do you keep your house in order, and do you have these things in place? We're not making judgments about those things. We just have to verify it's there. And so again, I think payers, regulators, consumers at the end of the day, when they're making decisions, whether it's about payment, whether it's about regulation, whether it's about purchasing, as far as who I'm going to see and access care from, it comes down to where am I getting the best value and where am I actually going to get the best care, and who's providing that. So again, I think we have a responsibility and an opportunity at CHQI to make sure that we're helping to transform healthcare accreditation in many ways, that we're seeing transformation of the healthcare industry itself. So again, moving away, or probably less emphasis down the road on process and structure measures than we might have, but I know Michael's going to be touching across some of the things and part of our vision moving forward. But I do think there's still, even beyond what's going on now, I think we're always going to see one element of the status quo in place, and that's going to be a move towards more types of efficiencies and synergies within the industry. I think we're seeing innovations even as far as like value-based purchasing, purchaser RFP requirements. We know that there's a heavy emphasis in all sectors of healthcare on evidence-based practice in medicine to make sure that we're making the best and most cost-effective decisions, as well as the ones that have the greatest clinical efficacy for the patients that we're treating. So again, and population health management in so many ways is becoming really one of the largest themes, because we are looking at patients now within special and specific populations as far as treatment groups. And I think as far as value-based purchasing and other types of models that are emerging out there, it's much easier to think about it within these types of frameworks and models. And so we start to see a merging of these themes really driving what we see as healthcare today. But I think we recognize there's an opportunity beyond the current kind of structure that's out there, and even the provisions in the ACA and other regulation that's out there at the federal and state level, that might speak to accreditation and quality assurance very specifically or formally. There's still an opportunity here to really move the ball and to really move the industry forward and to create a new model that really is focused on outcomes measures as the true metric of quality at the end of the day.
Great. Thank you, Doug. So, Michael, I guess the question is, with knowing kind of the landscape of both the strengths and some of the challenges associated with regulation and then accreditation, which obviously supplements regulations and also has, private purchasing standards as well. What are the future trends? Where are we heading? How can CHQI help, keep the ball rolling forward.
Gary, where I see this headed, in particular in the parity realm, is, I think about it this way. I have been really fortunate over the last few months to be very deeply involved daily in several different conversations that often don't overlap, unfortunately. There's, number one, a parity conversation. Number two, there's a measurement-based care conversation. I mean, there are a lot of folks that have done great work in measurement-based care advocacy, in particular in the mental health and addiction field. And related to the MBC conversation is the value-based purchasing conversation. There's been a lot of focus on that now in the mental health and addiction space. The CMS Innovation Center ran a full-day symposium several months ago on this topic. So, you have these three different conversations going on, and in fact, some of the same people are involved in all three of the conversations. So, really to think about where this is headed in a year or 5 years, hopefully closer to 1 year than to 5 years, but I think ultimately all of these three conversations have to be merged. I mean, I think we can't talk about parity if we're not going to talk about measurement-based care and value-based purchasing, because it just doesn't make sense. And so, to bring that concretely to the present in terms of developing our parity accreditation standards and our insurance appeal accreditation standards, we may not be able to get to the MBC and VBP conversations in depth in the first iteration of the standards. I think we're definitely going to touch on them because, for example, value-based purchasing or integrated care, which is a goal of integrated, it's a goal to integrate primary care, physical health care, and mental health care. If there are bundled payments for doing that, which a lot of folks in our country agree is a good thing, that has to be looked at from a parity lens, right? That you can't just say, okay, it's fine to do that, and parity doesn't come into play. So I think that these conversations, these different streams are going to merge sooner than we think. And so I think that's the perspective we bring to this work, that we know where this is headed, and we're trying to work with our committees right now and make sure that we understand that, okay, version 1 of parity might be very different from version 2 of parity.
Great, thank you. We've received a couple questions, so I just want to make sure we kind of wrap up and ask those questions. So as we kind of wrap up, again, I would encourage everybody can get involved. We're still taking a couple nominees for the Standards Committee. CHQI has 2 other accreditation programs that we have not announced yet that we'll be working on in 2018. So CHQI will continue to what it views as, plugging in the gaps, creating national standards, and we're excited about that. And again, this involves a community, and we'd love to get you involved and all the stakeholders to help drive the mission. We'll continue offering education webinars like this to maintain our transparency. If you happen to be a potential organization that is interested in one of our accreditations, please reach out to our staff. The beta test cycle is always a good way to kind of dip your toe in the water, see what we're up to. And as we move to the public comment periods, we believe in transparency, so we will send out the standards for review and look forward to your constructive feedback. We've just started a blog at chqi.com. You can maintain that. We're happy to have a blog submitted and publish that as well. So looking forward to enhanced connectivity going forward. So as we kind of wrap up, let me ask a couple questions. We've had a couple come through. The first was, and Michael, I think it's kind of focused on you, but one of the attendees asked if, in fact, whether at the federal or state level, the parity regulations are fundamentally changed. Let's just assume somehow aspects of the, let's assume that the mental health, essential health benefit, for example, is repealed by, that was, part of the Affordable Care Act, or states, somehow change the regulatory enforcement. How does that impact actually the parity accreditation program going forward?
Well, I think the answer is, it could be complicated, but I think that it to the extent that there is and will continue to be overlapping federal and state jurisdiction over a good chunk of the employer-sponsored healthcare market. About 50% or more of the employer-sponsored market is fully insured, which means that the feds have enforcement authority and state insurance commissioners have enforcement authority. Now, if it's self-insured, only the feds have enforcement authority. But I think your question relates to the non-group market, the individual market, and if the the Federal Parity Act is not a benefit mandate, but many states do have mandates, requirements, just in state law, leaving aside the Affordable Care Act, requirements for covering mental health and addiction treatment. So if we do see a rollback of essential health benefits, I think we're going to have to focus on the various state laws, which again is something that we're trying to address in the context of parity. We're trying to have our standards be applicable both to federal and state parity regimes.
I just will add, part of my excitement is understanding where the industry is today, what the regulatory landscape is. We have a sister organization called RegQuest that is doing very detailed research on the medical management system. So I do see parity as part of this larger medical management system. I think we all agree philosophically from a medical equity perspective, there's got to be more integration in terms of mental health and addiction services into physical health. So I think it's going to be great in terms of kind of our research arm with Clear Health Quality Institute, along with RegQuest, to continue understanding better what's going on to generate informed public policy discussion. So I would anticipate that even though we're a new organization, within a year or two, we'll actually, however the landscape shifts in terms of the regulatory requirements as expressed by new legislation, we'll actually be helping form some of those ideas and concepts to share. Another question just came in, just clarification. So Doug, if someone wants to apply for a beta test, do they just call the number on the screen to start the conversation?
Absolutely. Call the number on our website on the screen right here, or they certainly fill out an inquiry or contact request.
And I think our lead person is Rob Mikes on that, so just ask for Rob Mikes. So, all right, we're about to run over. I'll just ask one more question, which I think will help in terms of one of the issues with accreditation is just really documentation and compliance. So, in addition to kind of the administrative review, Doug, what are we going to be doing in terms of verifying compliance through kind of our, are we doing on-site visits, virtual demonstrations? Are we going to have random audits? How's that going to all work?
So actually, those are all on the menu, Gary. So certainly for the parity program, there's going to be a required on-site visit, or we also know that there are going to be potentially clinical focus visits for different types of telemedicine services. We are trying to maintain or retain the kind of unique feature that ATA created as part of their initial program, which was like direct-to-consumer services that are synchronous in particular. Those are things that can be done using a virtual demonstration. So again, it decreases the administrative burden, the obtrusiveness sometimes that people associate with accreditation processes. And I know we're committed to finding new and innovative ways to conduct our surveys moving forward as well, just as we're trying to innovate standards in how we evaluate. But again, we will also be doing random on-site visits as part of our process, for cause or without. And part of that is just to ensure that they're maintaining compliance with our standards beyond those points of review, either for initial or renewal application periods. So,
Great.
And Gary, this is just real quick. This is me putting on my former New York Assistant Attorney General hat, that we will have a mechanism for the public to file complaints with us about accredited organizations or about us if they feel that there are things that we should investigate.
And obviously, as within any accreditation organization, inter-rater reliability studies, our own QA processes will become very important. And so we're excited about this. So I just want to thank each of you for your comments and participation, not only for joining CHQI and becoming kind of part of this fantastic vision, but I also want to thank the attendees and your interest. And again, it's just my favorite part of this job is just creating these communities where we can really have informed discussion. We don't always know the answers right away, but as evidenced particularly by the parity journey, that that's taken another 3 to 4 months because we're going to do it right. And where we have consensus on 95% of the issues, there's that 5% that we need to continue working on. So I'm going to turn it back over to Brooke, kind of wrap up today's webinar.
Yes, and I would love to thank all of you for attending today. I hope you enjoyed this conversation. Just a reminder, this website and this webinar and all of our previous webinars are available on our website at at www.chqi.com. Thanks and have a great day.
And stay tuned, we'll be offering another webinar early next year. Thank you. Have a great day.